Hello everyone, I am Sulu Fan. Today, let's study aortic regurgitation, or AR. AR can be classified into acute AR and chronic AR. The causes of acute AR involves the effective endocarditis, trauma, aortic dissection, and the rupture of the artificial aortic valve. For chronic AR, the causes are usually associated with aortic valve disorder and the dilatation of the aortic root. Marfan syndrome and aortic aneurysm usually seen in the dilatation of aortic root. For acute AR, there is not enough time for the left ventricle to compensate within the short time. So, the end-diastolic pressure of the left ventricle will elevate abruptly, leading to the elevation of the left atrium pressure and pulmonary congestion finally. For chronic AR, sometimes the left ventricle will be compensated within short time. But if this regurgitation persists a long time, the preload will increase gradually and finally cause the left heart failure. The clinical manifestation of acute AR may be asymptomatic in mild type. But for the severe acute AR, patients will present acute left heart failure and hypertension, or even cardiogenic shock. In chronic AR, it may be asymptomatic for many years, and gradually the patients will present dyspnea, nocturnal angina, palpitations, and at the late stage, heart failure is very common. During the physical examination in acute AR, the pulse pressure may be normal. The S1 sound may be soft or absent. There is only a soft diastolic murmur. The appearance of the patient may be with cyanosis, shock, and vasoconstriction. For patients with chronic AR, we will detect the signs of widened pulse pressure. For example, the head bobbing, collapsing pulse, pistol shot, and the left ventricle impulse is usually heaving with the displacement to laterally and inferiorly. The typical sign of chronic AR is a high-pitched, blowing, decrescendo diastolic murmur, which can be heard best in the third intercostal space along the left sternal border. There may be Austin Flint murmur. This murmur resembles the murmur of the mitral stenosis. However, it is a soft, low-pitched, rumbling murmur, which appears in middle to late phase of the diastole. On the chest X-ray, there's only some non-specific change. For example, the enlarged left ventricle and dilated aorta. And in ECG, we may find the left ventricle hypertrophy, intraventricular conduction delay, the PR prolongation, sinus tachycardia, and some other non-specific change. Here is the echocardiography of the AR. From the colorful flow, we can recognize the dilated aortic root with aortic regurgitation. We may also find a dilated left ventricle and an enlarged left atrium. However, for acute AR, the structure of the left ventricle and the left atrium may be normal, but the aortic regurgitation exists. This diagram helps us to grade the severity of AR by both qualitative and quantitative methods. The complications of AR include infective endocarditis, ventricular arrhythmias, and heart failure. Regarding as the treatment, echocardiogram surveillance is used to monitor the progression. And we can choose some medicines, for example, the diuretics, vasodilators, digoxin, and also some methods to reduce the afterload. The surgical method, aortic valve replacement, is the definite method for patients with AR. The patients with symptoms at rest or exercise, or if the ejection fraction drops below 50%, or the left ventricle becomes dilated, patients with AR need the surgery. That's the end of this class. Goodbye.